All right, so this was a session that I'm really quite happy the program committee let us do. I'm going to introduce it and then bring up Drs. Mary Politi and Dr. Tony Bach. The title of the session is The Power of Words in Oncology Care. I'll provide an introduction to communicating cancer, and then both Mary and Tony can come up and give us their thoughts on this topic as well. The objectives of this whole session are here. It's to really understand that the words we use have dual meanings, and it's true in a lot of other aspects of communication, but it's particularly relevant when we're talking about cancer and its treatments. And the point is to heighten your awareness of the power of communication for women and men confronting a cancer diagnosis, and discuss ways to incorporate more sensitivity into communications, particularly around prognosis, not necessarily around end of life, but particularly around prognosis. This is a slide that I'm sure every one of us have seen multiple times in the last 3 days already. It's the epidemiology of cancer, nearly 2 million cases in the U.S. alone. Almost 6,000 deaths. 1 in 4 deaths in the U.S. is due to cancer. African Americans appear to be at a greater risk for some types of cancer compared to white people. But over 14 million survivors have a history of cancer. And when I say that, it's always kind of interesting what you think about when you think about a cancer survivor. Typically, I think most of us in practice don't think of people who are continuing on chemotherapy as a survivor of cancer. They're actively getting treated for cancer, and their needs may be different. But over 14 million people have been diagnosed with cancer. So they may be living with cancer, they may be free of cancer, free of disease right now, but that's a statistic, and that's what we're dealing with. The evolution of this session came about from a blog article that I write. I'm a columnist on ASCO Connection, and one of the blogs I originally wrote, this was back last year, was on the power of words. And I related this story about an experience I had when I was at Sloan Kettering, where a patient had progressed on ovarian cancer, and I'd met with her in a very sensitive way. But one of the first things out of my mouth was, you know, I'm really sorry to tell you that you failed treatment and we need to move on. And she started to cry. And her words to me were, I'm sorry I let you down. You know, I'm sorry I failed. I certainly didn't mean to fail. And it was not what any of us mean when we see failure or salvage. You know, it's not what we mean, but the intention coming at the heels of something so emotionally devastating can be interpreted very differently. And so that was what I termed here a watershed moment for my career, and I've sort of become very sensitized to how I speak, and I've sort of, you know, consciously tried not to use certain terms. So why is this important? Why do I think we're addressing it in this session? It's because communication matters. These are some comments that I got on that blog post. I have metastatic breast cancer early on. My doctor said we need to restage you. Yes, you know, versus having scans to assess effectiveness. And for someone dealing with cancer, when you say restaging, the hope was you were wrong. I'm going to restage you because you might not have metastatic disease. That's how she had interpreted it. And I thought I never actually considered that. I still use the term restaging all the time. But again, for someone dealing with the disease, everything we say can potentially put someone down or potentially give them hope, false or not. War on cancer, it's another term, it's way used, you know, in our society. We are fighting the war on cancer. It's, you know, John Donne said it's a cannon shot, a siege that blows up the heart. Louis Pasteur used it in infectious diseases, you know, describing the germ theory as an invasion. Richard Nixon is the one, though, who put that term into oncology care. He described the war on cancer, and that's what we've been fighting till today. But a war implies battles won and lost. So does that make the patients the soldiers? And does it make the doctors the generals? You know, does it mean mammography or the tools we screen for recurrence and metastatic? Are those our guards? Are those the guards that we employ? And is chemotherapy then the weapons? I mean, I've had a lot of patients on adjuvant therapy go through a fear of recurrence at the end of treatment because I'm taking away their weapons, right? So it's not only us that buy into this sort of mentality of cancer is a war, it's our patients. But go on the flip side, how many obituaries have you read where the person who's just died says, unfortunately, she lost her battle to cancer? So death is a defeat. And it comes to bite us, I think, when we talk about end of life. Because it's about, you're losing the battle to cancer and it's time to withdraw. This is, again, something that was placed on a blog, coming on the heels of the war on drugs, coming on the war on terror. There's a war on cancer too. How many fronts can we possibly hold? Perception of cancer as a battle seems grossly unhelpful when someone's trying to accept that they have cancer. If you're in a fight, you win or you lose. The other thing that I thought was incredibly thought-provoking came actually from television. This is Sex and the City. This is Samantha Jones. There was an episode where she got breast cancer, and she met with a surgeon, an oncological surgeon. And the discussion I thought was just so relevant. I don't understand how this happened. It could be genetics. But since there's no breast cancer in your family, it could be a lot of things. Diet, lifestyle. What do you mean by lifestyle? Some studies have shown women who haven't had children have an increased risk of breast cancer. So, I brought this on myself. No, I'm just giving you basic. I think we're done. Maybe I wasn't clear. Give me my chart. I'm going to find a woman, some hot woman doctor who understands what this is all about. I just meant, statistically, you're lucky to have touched my breasts. I love that. But again, it's, when we talk about risk factors, when we talk about genetics, part of my job on my disclosures, I write for Up to Date. So I did this huge thing on prevention of breast cancer. And, we were trying to see what is a modifiable risk factor versus what is not modifiable. Having babies when you're young, is that a modifiable risk factor or a non-modifiable risk factor? When you start to think about it, it's like, how do I tell someone who has breast cancer what the risk factors were that might have led to the development without having her seem it's her fault? I think the most relevant one today is obesity. It's like, well, a risk factor for a lot of cancers is obesity. And it's like, well, she's sitting here and she's obese and she has breast cancer. I still don't know how to navigate that one. At least you caught it early. This is actually something that I've read a lot about in the blogs. Consider what that might mean, though. Early stage usually does mean excellent prognosis. An early stage, when we say it, means you have less to worry about compared to somebody with advanced disease. Early stage probably means, to some women, with breast cancer, for example, or colon cancer for that matter, you won't need any further treatment after surgery. You won't need chemo, you won't need radiation. But probably to a patient, early stage means, oh, this is not going to kill me. But is that true? This is, again, a comment that came to me. The comment about early stages dismisses the fact that I've been living with cancer for months. The tests, the scans, the appointments, procedures, surgery, work, tests, scans, procedures, chemo, radiation, follow-up. Then there's always the wondering if there will be a recurrence. At least they caught it early, past the salt and pepper. Okay, so it's sort of this acknowledgement that cancer is a journey for most people, and I don't think we as oncologists kind of realize that. I am the first to admit, when I'm done with chemotherapy with a patient, I want to break out the balloons and say, congratulations, you're done. Go out and live. But what does that exactly mean? And I think for some patients, it's a harder thing to understand what just happened to them. You'll look fine even without hair. It's not something that we may necessarily say. It might be something that their partners say to them. I want you alive. I want you with me. The hair is not an issue. But you have to realize that hair loss is traumatic. And for women undergoing treatment for breast cancer, over 50% of them are traumatized by hair loss. Trivializing the effect is probably detrimental. And there's a rare risk, particularly with the taxanes, that alopecia may be persistent. In fact, this was an article out of the Globe and Mail in Toronto. Of that 1%, one woman in that 1% after docetaxel whose hair never came back. It's devastating. With no hair, there's no going back to being normal. Go and live your life. I kind of mentioned this already. The end of treatment, there's actually a well-recognized psychological state following treatment of cancer called fear of recurrence. And it's really met with a time of increased anxiety. It's where the expectations are unclear. Women are, I treat a lot of gynecologic and breast cancers. It's those patients who say, yes, treatment's over, but why can't I do what I used to do? Why can't I work full time? Why am I tired all the time? Why am I trembling when I first wake up in the morning? Or why does the phone make me so anxious? It's a new normal, and I don't know how well we do as a community in sort of exploring that or even explaining that to some patients. Because, all survivors will require follow-up. So when we're throwing, the confetti and giving them balloons, we're also handing them an appointment slip saying, I'm going to see you in 3 months with new whatever. We'll do a bone scan in 3 months or a repeat CT scan in a year. So they're never freed from that experience. I think it gets easier to live with the longer someone is alive with cancer. So the bottom line is that oncology for all of us it's an extreme model of medicine. I cannot really think of another field in medicine where the emotional gamut that we experience as oncologists and our patients experience can go from high to low, and it can change within months. The disease is unpredictable. The diagnosis is dire no matter what. And even that woman with a stage 1A uterine cancer has a risk it's going to come back. And we can never tell them, you're cured, you're 100% certain this will not happen to you again. Patients will experience anxiety, uncertainty, and distress. And as much as the most kind oncologist, the smartest guy speaking on a plenary stage is, none of us can alleviate that experience. And I think that's one of the things that we should acknowledge and accept and face the fact that we are human and we can only take someone so far, and then they kind of have to go too. So we approach this as much as our patients. So what we say biology, we talk about natural history, we talk about treatments, but what she hears may be completely different. The biology, it's bad, I'm going to die. Natural history, this is really bad, and I'm going to die. Treatment options, these sound bad. Either I'm going to die or these treatments are going to kill me. And I wonder if my oncologist just gets tired of saying, wah, wah, wah all day. You wonder how much they actually hear. So the bottom line is that patients want information, and I think this session hopefully will give you some of those, ideas of how to do that. But they don't want to lose hope. So how do we engage cognitively with patients, but engage effectively? Okay, so how do we meet their needs while reading them where they are emotionally? And I think that's going to be the topic of this presentation. And at this point, I'm going to bring up Dr. Mary Politi, who's an assistant professor at Washington University.